A modern dialysis machine generates a continuous stream of data throughout a 4-hour treatment session. It tracks blood flow rates, arterial pressures, and fluid removal down to the milliliter. Yet, despite this high volume of telemetry, most clinics operate entirely in the present tense, reacting to sudden drops in blood pressure or cramping only after the patient is already in distress. This delay happens because the information generated by the dialysis machines is trapped. It is siloed across isolated hardware, manually written paper charts, and disconnected electronic health record systems that do not interact. This graphic maps the systemic impact of that fragmentation. Between 20 and 50% of a nurse's shift is consumed by clerical tasks, primarily retyping laboratory results and treatment notes from the machine into separate portals. When highly trained clinical staff are repurposed as manual data transcribers, the entire facility suffers. The electronic health record remains fragmented, and the repetitive nature of manual entry under severe time pressure significantly increases the risk of fatigue-related mistakes, like missing a critical alert or incorrectly logging a session's fluid volume. Nephrologists face a similar bottleneck. Instead of viewing a single longitudinal timeline of a patient's telemetry, they are forced to piece together scattered vital signs and historical lab trends long after the session has ended. Because this review happens retrospectively, doctors lack the real-time visibility needed to anticipate intradialytic complications, like sudden hypotension, before the physical symptoms manifest on the clinic floor. Relying on human transcription to move critical health data creates a severe operational drag. It guarantees that clinical decisions will always lag behind the patient's physical condition, making proactive, personalized care impossible to deliver. The data deficit extends beyond the clinic walls. For a dialysis patient, the time between sessions, the interdialytic period, is exactly when their clinical trajectory is determined. This infographic outlines the specific hurdles of that interdialytic period. On the left, we see the extreme complexity of a renal diet. Patients are required to track strict, overlapping limits on sodium, potassium, and phosphorus to avoid cardiovascular distress. The standard protocol of handing out educational brochures and providing traditional nutritional counseling rarely translates into long-term adherence. The burden of manually interpreting complex food labels and logging daily intake overwhelms most patients. Moving to the right side of the chart, this failure in dietary management directly impacts fluid tracking. When patients cannot accurately monitor their liquid intake between treatments, they arise at their next appointment with excessive interdialytic weight gain, or IWG. High IWG means the clinical team must remove a larger volume of fluid in the same 4-hour window. This aggressive ultrafiltration severely strains the cardiovascular system, directly triggering the crashes and severe cramping that disrupt the session. Until a clinic can automatically capture and correct out-of-clinic behavior, the in-center treatment will remain an ongoing cycle of managing preventable cardiovascular stress. To break this cycle and deploy predictive analytics, a clinic must first construct a unified digital backbone that standardizes every piece of patient information into a single language. The first step is closing the interdialytic data gap. By deploying an AI-powered mobile app, patients can scan food labels and log fluid intake directly from their phones, capturing their out-of-clinic behavior precisely. Simultaneously, a dedicated tablet application for the nursing staff replaces paper charting. It structures the pre-dialysis assessments, standardizes the recording of vital signs, and digitizes all mid-session interventions. This diagram details hardware capturing telemetry. The edge layer connects physical dialysis machines directly into local network gateways. Utilizing standard protocols, they normalize raw data from different manufacturers. This telemetry then lands in a centralized cloud data store built on an HL7 FHIR semantic model. HL7 FHIR is the critical translation standard. It takes the disparate inputs, the raw machine telemetry, the lab results, and the patient's dietary logs, and forces them into a single, cohesive medical vocabulary. The density of this new data stream is immense. Parameters like blood flow rates, ultrafiltration targets, and venous pressure are captured and updated every 1 to 5 seconds throughout the entire session. By building this edge-to-cloud pipeline, the clinic converts isolated hardware exhaust into a high-frequency, structured dataset. It provides the exact foundation required to run advanced machine learning models. With a continuous stream of clean data secured, The system moves from simply storing information to analyzing it in real time. This architecture outlines the causal multimodal dialysis twin, or CMDT. It acts as an AI co-pilot, fusing historical patient profiles with live streaming telemetry. Before connection, it ingests baseline metrics, demographics, and labs. Once treatment begins, it continuously integrates live machine settings and interval vital vitals. To process this information, XGBoost and random forest algorithms act as complex decision trees, evaluating incoming streams against thousands of previous sessions to calculate an immediate risk score. They identify subtle patterns of cardiovascular deterioration that human observation would easily miss. The CMDT then runs counterfactual simulations. It calculates exactly what might happen to the patient's stability if specific treatment variables, like the ultrafiltration rate, are adjusted in real time. This capability shifts the entire clinical posture. Instead of waiting for a machine alarm to sound or a patient to crash, the care team receives the exact recommendations needed to proactively adjust the treatment before symptoms of hypotension manifest. When edge hardware, standardized cloud architecture, and predictive AI models are integrated, they form a single closed-loop ecosystem. The clinic moves from fragmented data collection to synchronized intelligence. The system completes the loop by routing the CMDT's calculations directly back to the clinic floor, surfacing these predictive insights on centralized dashboards for the medical staff. This diagram illustrates decision support for the nephrologist. Doctors receive specific, actionable recommendations, like dry weight optimization and anemia targets. These AI outputs act as assistive guidance. They rank the safest next actions, but require medical authorization to execute, preserving a strict clinician-in-the-loop safety standard. Back on the clinic floor, the operational impact is immediate. By automating machine integration, nursing staff experience a proven 50% reduction in documentation time, freeing them to focus entirely on physical patient care. The architectural advantage compounds over time. Every completed session, every intervention, and every patient outcome is fed back into the central data lake, continuously retraining and sharpening the AI risk models. Because the underlying data is standardized through HL7 Fire, this entire intelligence layer can be deployed seamlessly across multi-region hospital networks and localized global cloud instances. By architecting a unified data backbone, dialysis providers eliminate the friction of manual operations. They convert machine exhaust into predictive foresight, significantly increasing the volume of event-free treatments and establishing a precise, proactive standard for renal care.